Okay, hello everyone. Welcome to another lecture of the series of Introduction to Thoracic Surgery for Junior Thoracic Doctors. So as a young junior resident, you will be asked to attend the outpatient clinics, either to assess or to attend on the behalf of the consultant to see the patients. And so these are a series of lectures to help you during the preoperative assessment. So you need first to know why are we going to do the preoperative assessment, how to assess, what investigations and procedure we need to do, what the complications after this lungs resection, because this will be needed in counseling the patient, consenting the patient. So we're going to have a quick discussion about it. And finally, I'm going to have a quick also introduction about how to manage the chest drains. So first, as you already know, there is the increased life expectancy worldwide. And because of also lung cancer screening, we are expecting that we are seeing a population of patients who have complex comorbidities, patients with old age, frailty, increased comorbidities, complex diseases, patient with cardiac diseases, patient who needs special care. This group of patients will require meticulous preoperative assessment. And we will need to identify the risk factors beforehand to see if the patient is first of all if he or she is amenable for resection and for surgery, or if he or she has risk factors that can be optimized before the procedure to allow for better recovery. So first, during the preoperative assessment in the clinic, we need to establish whether the tumors are resectable in the first place, whether the patient is fit to go for operation, what are risk factors, and are they modifiable? So, for example, there are risk factors that cannot be modifiable, like the age, for example, but there are other risk factors like smoking, like anemia, like malnutrition that can be optimized. And we also have to consider whether the patient should be seen with a cardiologist or the consultant anesthetist before going or deciding to go for the operation, whether the patient will need an extra care postoperatively rather than the ward bed. Does the patient needs an ITU? If the patient, for example, have a trachea resection, if the patient has a myasthenia gravis, those patients will require an ITU. Do we need extra resources? Are we expecting a complex procedure? Are we expecting bleeding? And these things should be established within the preoperative assessment. The other important thing is these things need to be ascertained in order to counsel the patient. So, for example, if the patient has many risk factors which are non-modifiable, or the patient has complex history, then we can counsel him about non-surgical options, because as we will mention later, for example, if the patient have a lung cancer and his lung functions are suboptimal, the patient is frail and he's have higher risk procedure. And then we can counsel the patient about SABR, which is the stereotactic ablative therapy. Or if the patient has, for example, a metastasis, we can also counsel him for RFA. So there are several non-surgical options which might be suboptimal, but can be safer for this group of patients, and we have to discuss that with them. So the first thing we need to address is the resectability, and this is an anatomical term. It's related to the tumor itself, to the extent of the growth of the tumor, the involvement of the surrounding structures, the involvement of the regional lymph nodes, whether the tumor has spread. So if the tumor has metastases, we can't do surgery because we were not able to control the tumor. And it's important to assess the surrounding structure. If, for example, if the tumor is a Bankos tumor or any tumor is involving spinal cord, for example, you can't resect it. So this is more related to the achieving free margins. If you had an anterior mediastinal mass and it is involving both phrenic, you can't sacrifice the whole both phrenic, so you won't be able to achieve free margin. And at this point, then you have to consider other non-surgical options. So operability is another term which is related to the patient himself. So the tumor can be resectable and can be removed with free margins, but the patient himself or herself is not fit to go through the operation. It could be because the patient has significant medical comorbidities, like, for example, if a patient has very frail, have very low lung functions, the patient has left main disease, so it is risky for him to go through general anesthesia, and we're not expecting that he will going to recover very well after the operation. So this group of patients, we can do either to refer them to non-surgical options if they are if the risk factors are not modifiable, or we can try to optimize the risk factors and reassess later. It's important to know that all the thoracic procedures have severe physiological impacts. So the patient need to have certain degree of fitness, the baseline fitness before going through the operation. Of course, depends on the invasiveness of the procedure, but the stress of the thoracic procedure itself is impactful. So the patient should have certain level of fitness before. For example, one of these is that, as you know, the one of the chest wall is richly innervated, so irritation of the nerves will cause severe pain. So that's why we have multimodal analgesia. Patient will have, for example, epidural or paravertebral catheters, and the patient will still be in pain, particularly in the very first few days, and this will cause him to stop or to limit his respiratory mechanics and ventilation. So patient would try to minimize his coughing, his chest inflation, and this will cause atelectasis, will cause retention of secretion, and increase risk of pneumonia. Um, and there's also an element of the diaphragmatic dysfunction, where the patient have also chest drain inside. They have irritation of the chest wall, causing more pain, and all this will contribute, in addition to the analgesia and respiratory depression, to increase the risk of pulmonary complications. So here we have to assess risk factors. So first we look to the patient as in a holistic approach. So check the patient age. Age itself is not an absolute contraindication for the procedure, but we have to consider that in patients with advanced age is a risk factor, because there's increase in all cumulative risk factors, increased risk of atherosclerosis, of COPD, of all the risk factors are accumulating and increase with advanced age. Patient will have higher risk of frailty, of cardiac diseases. So the age itself is not a contraindication, but the complications are related more to the increased and the risk factors. The other thing is we have to ask the patient what are their baseline activities. This will have a very good idea about what is the patient's lung functions. So we ask the patient simply how far he can go or she go without getting breathlessness. How many flight of stairs he can go. Does he need to take frequent rest to take the breath? Or how or she are doing their house chores with shopping, or going around? Is he bed or she or he bed or chair bound? All these will give you an idea about the performance status of the lung functions. Another important element is smoking. So smoking, despite that most of the patients with lung cancers will already have smoking, and most of them have tried several smoking cessation therapies like nicotine replacement, group therapy. Some of them have tried vaping or electrical cigarettes. Some of them just like they felt they want to be able to cut off cigarettes. Some of them tried to decrease the smoking, the number of cigarettes, but unsuccessful to stop it completely. So it's very important for all thoracic surgeons to have some sort of smoking cessation training. And then there are several resources on the internet that you can go, like the Tobacco Institute, and there are several books as well and leaflets to help you to guide the patient and counsel the patient about smoking cessation. It's very important to address that. It's true that smoking might have led to the lung cancer, but stopping smoking is not very late, and it will have a very good impact on the recovery, decreases all the risks of postoperative pneumonia and chest infection. And preferably patients should stop sometime, like a few weeks before the operation, because if they stop very close to the operation, then they will have all these secretions and the mucociliary clearance mechanism. So this will make the operation somehow more difficult. So it's better for them to address this situation a few weeks before the operation, help them, give them a guide, prescribe the drugs, medications, give them nicotine replacement therapy, even refer them to the therapist to help them with the smoking cessation. There are several apps and things to help them. And it's important, most of the patients, when they have already the lung cancer diagnosis, they are highly motivated to stop smoking. So this is a good chance to address this to the patients. Um, in terms of the performance status, there are several scores. Usually one of them is a Karnofsky score. So you ask the patient what he's doing or she doing in terms of day-to-day activities and score him, usually the normal one from 80 to 100. There's another commonly used score, the WHO score. So with a score, you also ask the patient how dependable or independent he is and score him. Patients who are bid or chair-bidden or unable of self-care have poor postoperative outcomes. Um, The other thing is the pre-existing pulmonary diseases, patient with particular COPD, patient with interstitial lung diseases, bronchiectasis, patient with large hiatal hernias will also have adhesions, and this will be difficult dissection during the operation. So this is an important thing to establish beforehand. Patient with COPD, particularly patient who have lung cancers, if the tumor is in the upper lobes, because usually emphysema is more upper lobe dominant, and they are taking the upper lobe, patient might benefit from that because it's a sort of lung volume reduction surgery. You're removing the disease part of the lung. If you are removing the lower lobe or middle lobe, then you have to consider what is the post-operative FEV1, because these are diseased lungs. Patients with interstitial lung disease and bronchiectasis have higher risk of developing pneumonia, empyema, and they have low threshold of mechanical ventilation, need of the mechanical ventilation or invasive or supportive ventilation. Patients with previous lung resection for other surgery, for other lung cancers, you might consider having wedge or a segment rather than a lobe, because this patient will have already previous resections. One of the other complications or one of the other risk factors that you have to address is the low BMI. This will also increase the risk of preoperative complication. And this is one of the modifiable risk factors because you can optimize the nutrition of the patient. You can refer him to a dietitian or nutritionist. You can offer him protein supplements to help him to gain weight during this time and to build his muscles. It's also important to give the patient the exercise leaflets or tell him how to exercise in order to optimize his body muscles and respiratory muscles. Other risk factors are frailty, and frailty doesn't have a definitive an established definition. So this is more of a syndrome with patients with advanced age where there's a progressive physiological decline, and these patients are more dependable, and they are more vulnerable, and they have increased risk of complications. Usually they are known to the local services, and these patients will need an extra care during the preparation to assess whether they will benefit from the surgery or whether they can go through an invasive procedure. The other item is anemia, which will appear through the investigations. And despite that, it has no direct impact on the mortality, but it increases risk of the blood transfusion when the patient is advanced age and having cardiac problems, and you add the risk of anemia as well, so you increase the risk of the postoperative complications. The cardiac disease. So remember these patients, if advanced age, if the patient have already smokers, they are at risk of cardiac disease. And the combination of a pulmonary cardiac disease will make a worse outcome. So you have to make sure that the patient doesn't have a coronary artery disease. And so you simply ask the patient about the chest pains, if he has a significant previous cardiac disease, if he have a PCI or CABG. If the patient, for example, is coming for empyema, IV drug abuser, you have to make sure the patient has no infective endocarditis, has no vegetations, has no severe tricuspid regurg. This will cause also it will worsen the outcomes, so he will need another level of care. A patient with a left main disease might have a risk of going through the general anesthesia. So it's better to start to do the revascularization first, BCI or CABG, and then do the lung surgery. It's also important patients having lung volume reduction surgery or any patient with pulmonary hypertension. Taking part of the lung might cause RV strain, so this also need to be excluded. And there are several ways to scores in terms of assessment of the cardiac risk. So you can ask the patient about the New York Heart Association's score for dyspnea, how much effort he's doing before starting to have a breathlessness and chest pain. You can also ask for ECG, which is also a routine assessment. Check if there's any arrhythmias, if the patient is AF, if the patient has a dilated left atrium, if the patient is on any blood thinners or dual antiplatelets, because these things need to be stopped before the procedure. And the patient might need a cardiology review if if it hasn't been already have a cardiology review. They might also ask for an echo, and then also might need to be seen by the anesthetist. There is one of the scores, which are a revised cardiac index score, to assess the patient, to assess the risk of surgery, whether it is a pneumonectomy or lobectomy, assess the risk of history of the ischemic heart disease, whether the patient had previous MI or angina, the risk of congestive heart failure, history of congestive heart failure or diabetes, or history of peripheral vascular disease or TIA, cerebrovascular accidents, and then assess the risk, score the risk, and then take a decision whether the patient needs more cardiology review or an echo, or the patient doesn't need any of these consultations. There's another investigation that should be performed for all patients going a lung volume reduction surgery, lung resection surgery, and this is called a tripartite risk assessment. So there are three limbs. First, we assess the preoperative cardiac events, and the preoperative risk of death, and the postoperative risk of dyspnea. So we've already spoken about the postoperative cardiac events. So simply by history, the ECG, and assessing the patients whether they have any symptoms suggestive of cardiac disease. If looking through the investigation and risk stratification, like a revised cardiac index, and then assess the need of more of a cardiology specialist review or the anesthetist, or just we can go without doing this. The other risk assessment score is the preoperative risk of death, which is the thoracic score, which we're going to discuss in a minute. And there's also the postoperative risk of dyspnea, which is an important thing. And this is through the lung function tests and the transfer factors. So address also for after doing this assessment, we will address if there's any potential modifiable risk factors. As I mentioned before, patients have smoking, patients are having low PMI or anemia, or patients are frail, these things, and patients have sedentary lifestyle. All these factors can be optimized, and this will improve the recovery. And then we will counsel the patient about the risks based on all these assessment scores and based on the investigations. If he matched the national or international levels of or mortality risks factor, like 2% for lobectomy, 5% for pneumonectomy, if we quoted him for a higher risk because of his risk or comorbidities, then this will help the patient to make an informed decision whether he would accept to go through a high risk procedure, or he would just defer the procedure and go to non-surgical options. So the postoperative mortality risk, there's in the cardiac surgery, there's the Euro score. And however, in the thoracic surgery, the thoracic score is not as, let's say, not very representative as in the Euro score. It has been already developed by in the French population, and it was for pneumonectomy. So if you go Google it and try to go through the calculator and do it online, you will find it here in the procedure class. It is pneumonectomy or non-pneumonectomy, which is not very representative about the patient risk factors. So it just classes all the procedure as pneumonectomy or non-pneumonectomy that include any other thing apart from pneumonectomy. That could be mediastinal mass, could be esophageectomy, could be any other procedure, which is not very accurate. And the other thing is that it doesn't take into account the TNM staging, the tumor staging, or anything. So the main items here is the age, the gender, the ASA classification, performance status, dyspnea scores, and the other comorbidity scores. So there are 10 comorbidity scores. They are already known on this score. So one of them is diabetes, smoking, alcoholism, hypertension, peripheral vascular diseases, obesities, and other risk factors like hyperlipidemia. So it's less common. It is used, but it's not as dependable as the Euro score in the cardiac surgery. And there also you'll find some papers discussing whether it could be applied to wider population, because it has been initially used in the French population. So we usually, for post-operative mortality, go by the national international risks, which is the national cohort or auditing. So if it is usually 2% for the lobectomies and 5% for pneumonectomy, and this is more accurate data that's used in day-to-day assessment of the patient. And then you can increase the risk, like crudely, roughly based on the patient's comorbidities and risk factors. Another important element is assessment of post-operative dyspnea, because this is a decisive on whether the patient will go to a surgery or not, or whether he's a high risk. So the basic assessment is a pulmonary function test, and then there are other more complex tests, investigations, which is a low technology exercise testing like shuttle or 6-minute walk test or stair assessment, or a high tech, which is a cardiopulmonary exercise test. So you're already familiar with this pulmonary function test and the lung volumes. These are the flow volume lobes. So usually this is the inhalation. This is the smooth inhalation, the curve, which is downwards, and then the gradual return to zero, and then the sharp peak with the exhalation. And this lobe, this flow volume lobe, is important to determine patients with obstructive, restrictive lung diseases, whether there's an upper or fixed or variable airway obstruction. So this is the normal loop, and then the obstructive loop will show problem with the exhalation. So it will go through a slower descent, and there are the restrictive lung volumes, which are shrunk upper and lower inhalation, exhalation, and volume curves. And one of the most important item on the lung function test or pulmonary function test is the FEV1. So FEV1 is the amount of the air expired on the first second, and it's called forced expiratory volume 1. And this is one of the single most important determinant of the patient's lung functions, as well as FVC and DLCO. But FEV1 is one of the important parameters. There's another body plethysmography. So body plethysmography is to measure the total lung capacity and RV, which is important in patient going through lung volume reduction, when we make sure that the patient is having hyperinflated lungs and they are eligible for reduction surgery. So an important formula that is used in day-to-day activities when assessing the patient with for lung resection is the post-operative FEV1. So you check first the FEV1 that is on the lung functions, and then you assess the segments that are potential to be removed, and you have to know the segments on each lobe. So for right upper lobe is 3, the middle lobe is 2, the lower is 5, and then you assess the number. You do the formula. You assess the number of the segment to be removed minus 19, which is the total lung segments. And it's important to remember that obstructed segments are taken away. So because these are non-functional segments, so obstructive segments are taken away from the number of segments to be removed. And then you assess whether, if it is the post-operative value is less than 40%, then we need to do a more technical test to assess if the patient this is a true representation of his lung functions. So one of the tests is the shuttle walk test or incremental shuttle walk test, to ask the patient to go to move around through the shuttles, which are some distance around, and usually a patient should be able to do 25 shuttles. If he's less, then it's considered as a high risk. The stair climbing test, the patients going through pneumonectomy should ideally go for 5 flights of stairs. Patients going through 2 flights of stairs is equal to 12 milliliter per minute per kg, which is acceptable in the cardiopulmonary exercise test. The other one, 6-minute walk test, you ask the patient to go the path of the walk and then measure the distance that you're able to achieve in the 6 minutes. Usually patients should be able to achieve more than 400 meters. If the patient fails, or we still need an accurate and more invasive assessment of his cardiopulmonary exercise, we will go through this cardiopulmonary exercise testing. And it gives a plethora of data and information. It identifies whether the patient have a risk of lung resection. There is a patient's the oxygen consumption is allows the patient to have the operation with a low risk, or is the patient is categorized as moderate risk, or the patient cannot have the procedure because there's a very high risk of postoperative dyspnea. It's also differentiate between the cardiac and respiratory limitation. So with the magic number we're looking for is 15 milliliter per kg. Less than that, less than 10 would be considered a high risk. So as you can see, it is assessing, there's an ECG leads and there is assessing of the oxygens. So it offers loads of data. So usually it comes with nine plot graphs, and it gives idea about the cardiac limitation, the anabolic, the threshold. It gives much information about whether the patient have respiratory limitation or cardiac limitation. It has all an ECG lead, so you can also assess the patient if the patient have arrhythmias or he needs to stop the test because of the cardiac limitation. The understanding the test, or the graphs is very complex, so you need to go to further reading to understand it. Usually, the report will tell you what is the VO2 max, which is the number that we're looking for, so you can stratify the patient whether they are of low or high or moderate risk. So that is a summary of what we will do in the clinic. So if we took the history physical exam and do pulmonary function test and assess the post-operative, if you want to predict the post-operative, if you want from the formula, taking into account the segments which are obstructed will not be taken into account. So if it is a more than 40%, we can go for resection. Patients are considered as a low risk, or if the patient is have already cardiopulmonary exercise test with more than 10, then you are also safe to go through the procedure. If the patient has low post-operative FEV1, then you have to go through more invasive tests, which are either exercise testing, either low tech or high tech, and assess. If the patient have less than 20%, then you can't go for resection. If the patient have more than 10, from 20 to 40%, or VO2 from 10 to 15%, then you can consider the patient for resection, but counsel the patient that is a high risk procedure. So what are the diagnostic invasive or non-invasive modalities of assessment that we use in the clinic? Usually the patient who's been referred from the respiratory, either it's an incidental finding or done through, if a patient has, for example, under any other specialties for colorectal cancer or renal cancer and having surveillance of his lungs. So usually patients are referred with a CT chest. It should be a staging CT chest, so CT contrast of the chest and abdomen pelvis. And also patients will have a PET scan. Patients with carcinoid tumors will have a PET scan, which is another type of PET scan, and sometimes MRI liver as well. And this to exclude distant metastases. Patient with pancreas tumor or superior sulcus tumor and patient with expected chest wall involvement should have an MRI to give a clear idea whether there's chest wall involvement, which will require a more invasive procedure to resect the ribs and resect and reconstruct the chest wall. So this has to be identified beforehand. Patients, for example, undergoing diaphragmatic plication for phrenic palsy or diaphragmatic palsy should have fluoroscopy and the sniff test, and then assess the paradoxical movement of the diaphragm. In terms of staging, back to the lung cancer, if the patient has stage 2, should have a brain imaging, preferably CT scan. If there's a suspicious finding, they can go for MRI scan. Patient with stage 3 should have MRI brain in the first place. Also, we do for ABGs, particularly for patients having LVRS, and to assess whether the CO2 levels and the BO2, and also pulmonary function exercise tests, as we described before, ECG and echocardiography in patients who have risk factors or history suggestive of cardiac problems, and the routine bloods. Another important aspect to consider during the staging is the nodal levels or the nodal involvement. So these are stations of the lymph nodes. So the first level of the lymph nodes, which we call N1 disease, is with this part, which is the hilar and interlobar. So there's a hilar lymphadenopathy from their name, and that can be accessible usually during the operation through the VAS or open procedure. They can be also performed through the EPUS. And this is the stage. This is it's called station 10, hilar lymphadenopathy, and there's also the interlobar, which is sometimes called sumb lymph nodes, which is in the angle between the upper lower bronchus and the middle bronchus on the right side and the left side from the upper between the upper and the lower, and the other ones are just embedded in the lung parenchyma, so they are not accessible to be sampled. The other lymph node, the N2 disease, is most commonly used in practice as the upper and lower paratracheal lymph nodes, because these are one that you can take in the cervical mediastinoscopy. There is the subaortic and paraortic lymphadenopathy lymph nodes, the subcarinal lymph nodes, which is here, and these are mainly these lymph nodes can be taken by the EPUS or IUS or the cervical lymphadenopathy, the cervical mediastinoscopy, whereas the para-aortic and subaortic lymph nodes are only accessible through the anterior mediastinotomy, which is Chamberlain procedure, or through VATS. And there's also lymph nodes which can be accessible only through the VATS procedure or open procedure, like the pulmonary ligaments. There's also the esophageal, which you can also access through the EUS. So when do we need to sample these lymph nodes? So as I mentioned, that all the patients referred for lung cancer procedure will have a CT or PET scan and BET scan. So if we assess the size of these lymph nodes, particularly N2, we're talking about N2 mainly, and N1. So if we find that N1 is enlarged or active, so or the patient have a enlarged tumor, more than 3 centimeter or central tumor, then it is reasonable to go for a tissue confirmation and to make sure that these N2 disease are not involved. And we're talking about N2 disease because it's an advanced stage of cancer where we can consider non-surgical options. So we go for EPUS or EUS depending on which stage of lymph node we are targeting, and then ascertain that there's our negative lymph nodes, and then we can go to surgery. Patient without active or without metabolically active lymph nodes on the PET scan or not enlarged lymph nodes, then we can proceed without for surgery without mediastinal staging. If the mediastinal lymph nodes are positive on PET scan or CT scan or enlarged, then we have to do the EPUS or EOS. When the EPUS and EOS are less invasive than the cervical mediastinoscopy, because they are done under sedation. However, the sensitivity is less. They are unable to access or to retrieve the whole lymph nodes, so most of the sampling of the lymph nodes. If the proven to be positive, then we know that this is a positive lymph nodes. If they are negative, then we have to make sure that they are truly negative. So we can go for a mediastinoscopy, which is more invasive but give more accurate diagnosis because of accessibility, can access more lymph nodes, and they can retrieve most of the lymph nodes themselves. If the mediastinal lymph node is positive, then this is another stage tumor, so we have to consider multimodal treatment with a concurrent chemoradiotherapy or surgery and postoperative chemotherapy. So these are the invasive staging modalities. So you go ask the patient, you can ask the patient that you need for another invasive investigation, which will put him to sleep for cervical mediastinoscopy, for example, or Chamberlain or VATS, or EOS or EPUS, and then to establish the stage of the tumor and then take a decision based on that. So mediastinoscopy is not done now. This has been replaced by the video-assisted mediastinoscopy and VATS procedures in the US. So mainly the mediastinoscopy, which is one of the most commonly performed procedure, aims to retrieve the lymph nodes from the upper and lower paratracheal lymph node and the seventh lymph node, the subcranial lymph node. There's also the extended TIMLA-VAMLA mediastinoscopy, which aims for more of diagnostic and lymphadenectomy. So it aims for clearance of these lymph nodes, but these have a higher risk of injury to the recurrently injured nerve, particularly on the left side. And there's also the VATS can access all the lymph nodes. However, the Chamberlain procedure can access fifth and sixth because they are very tricky to establish. So it's the only way is either Chamberlain, which is anterior mediastinotomy, or VATS procedure. Okay, so cervical mediastinoscopy, if we see a patient with a central tumor or large tumor or N1 disease, or patient with a bit active lymphadenopathy, mediastinal lymphadenopathy, then we have to do an invasive mediastinal staging with our EBUS or EOS or cervical med. So when you see a patient for cervical mediastinoscopy, you have to assess whether he has a previous tracheostomy or not, because what we do the operation is do a small incision at the lower part of the neck, and then dissect to get to the pretracheal fascia. That's the plane we are aiming for. And then you can assess the lymph nodes on the upper and lower part trachea on both sides, and go for the seventh or the subcranial lymph node. So you go and you find the trachea just beneath the scope, as seen here, and then from the right and left side you treat the lymph nodes and you go to the subcranial. Usually we start with the subcranial lymph nodes and then go to the upper and lower. And because as you've seen, there are several structures here. So injury to the innominate, to the PA, to the aorta, all this will result in horrible bleeding. So you have to counsel the patient about the risk of bleeding and the risk of conversion to median sternotomy to control the bleeder if it is a major vessel. It's also a risk of injuring the lung on both sides, so there's a risk of pneumothorax and air leak and the need of inserted drain if needed. There's also risk of injury to the recurrent laryngeal nerve, which is an important thing to address to the patient. So, this is the risk of recurrent laryngeal nerve injury might leave the patient with temporary or permanent hoarseness of voice and difficult coughing. So these three things are mainly specific to the cervical meat and should be addressed to the patient. Despite that, this is a procedure already done as a day-case procedure, but in 1,000 patients, you need to do cervical. You need to do median sternotomy to control the bleeder. Another procedure is Chamberlain. This is the only way to get to station 5 and 6 of aortic and para-aortic together with the VATS. These are the only approaches to be able to sample these lymph nodes. So this is a small bar sterile incision, and you go like get into mammary vessels and get to the aortopulmonary nodes in the aortopulmonary window. So the TNM staging, I know that we've already been studying TNM7 as undergraduates. You probably also have had that. So it's important to know that's what changes in the TNM in the 8th edition. So I think it's better to see what were differences. So as you know, there was T1A, T1B. Now they added the TI, which is carcinoma in situ, and minimally invasive adenocarcinoma. And there are other details here about these the GGOs and the solid part of the tumor, but we're not going to talk about this today. There is an addition of another subcategory in T1, because there's with each 1 centimeter increase in the size of the tumor, there's a proportional increase on the risk of death. So that's why they had been subcategorized into 3 stages. And the G2B, instead of being up to 7 centimeter, is now up to 5 centimeters, and the 7 centimeter has becoming upgraded to T4. Other thing has been downgraded is the atelectasis. So previously atelectasis or pneumonitis, as we know, have been as T3, now it is T2, as well as the involvement of the main bronchus. So usually we would categorize as less than 2 centimeters or within 2 centimeters. Now it is any tumor involving the main bronchus, irrespective of the distance from the carina, will be T2. The diaphragm has been upgraded to T4. And the other thing with the M part or the metastases, there has been differentiation between M1B and M1C, which is oligometastasis. So in selected patients with single extrahepatic metastasis, they can benefit still from surgery. So collectively, we're going quickly to talk about the complications. So what are the type of lung resection? So we can go through pneumonectomy, which is less done now because there are several other non-surgical options that are around, and pneumonectomy is not done that much today. Bilobectomy, which is when we talk about bilobectomy, it's more referred to the right side, because if it's the left side, it will be a pneumonectomy. There's another sublobar resection. Sublobar resection is going to less than a lobe. So is you can either go through a wedge or anatomical segmentectomy. Remember that we talked about the segment before, and that there's 19 segments of the lungs. So if it is a tumor in the lingula, instead of taking the whole left upper lobe, you can take 2 segments out of the 5, and spare more of the lung to the patients. It is more meticulous and more technically demanding than the wedge, because with the wedge you just take the tumor with the rim of normal tissue or safety margin, but with anatomical segmentectomy you have to dissect on the vessel and the bronchus and ligate them. The approaches, they are conventional, the atherectomy, which is the posterolateral thoracotomy or anterior thoracotomy, muscle sparing or nerve sparing, and there's the video-assisted thoracoscopy, which is most of the procedure now are doing through the VATS. Usually, if it's a big tumor, central tumor, pneumonectomy or bilobectomy, you go for thoracotomy, of course, with chest wall involvement as well. And there's recently in some centers the robotic-assisted thoracoscopic surgery. So what are most complications are encountered in lung resection, and though we have to counsel the patient for them. So one of them is bleeding. Bleeding is the most common cause for conversion from VATS or RATS to an open procedure, because you have to control the bleeder, depending also on what is bleeders. If it's a bronchial vessel, while you're dissecting the lymph node, you can control it with just compression. If it is a lung parenchyma, you also can control, but BA mainly, you need to open and ligate or clamp and suture. So when the bleeding is, you have to counsel the patient about whether he's happy for blood transfusion. You have to assess if he's having any blood thinners or any antiplatelets that need to be stopped before the procedure to minimize the risk or to decrease the need for blood transfusion. Usually, it's important to remember, with particularly the BA bleeding. Usually, bleeding won't kill the patient, but response for the bleeding will kill the patient. So what will happen in this situation if you are assisting, if you are holding the camera, just retract the camera a bit to avoid the spillage of the camera and going out of the field, and then compress you will find the consultant or the operating registrar, whoever will apply compression, and then ask for the thoracotomy tray and prepare for the retractor, and ask the anesthetist to prepare blood for blood transfusion. So they will contact the blood bank to get the blood cross-matched and ready in the room. And they will ask for all the hemostatic agents. They will ask for the stitches, the clamps, and they will ask for senior assistant if needed, or another help. So this is usually what will happen in this situation. Pain. It is very important to address this complication to the patient and counsel the patient consented for him. So first, pain in the thoracic surgery, particularly in the chest cavity, is very common. One of the most painful incisions in the body. Despite that, we aim to minimize this by giving epidural, paravertebral, or regional blocks. A patient still have pain, and the pain might not resolve in a few patients.